Good evening, sir. I think we'll start off with this, another session of e-Gurukul. We'll introduce the speakers as they join in. I think Dr. Baldev sir needs no introduction. Welcome, sir. And for today's session, I have Dr. Rahul, our second year PG, for presenting a case. And we have Dr. Anagha Dubashi, our faculty, as a mentor. So I think we can start off with this. So Rahul, probably you can start sharing.
Don't wait for a minute.
Yes.
Good evening, friends. Welcome to this our Saturday e-Gurukul PG clinic. As we came to know that Dr. Raud is the presenter, I request all other participants to keep their video on as Dr. Nishi is ready. I request all other your colleagues to. I hope that Dr. Raud, can you identify your colleagues?
Yes, sir.
So that I come to know exactly and we can probably involve them in the discussion.
Yes. Dr. Viraj, Dr. Radhika, and Dr. Virat, please put on your videos.
Okay, fine.
Dr. Sarojini, please.
Fine. So I think good numbers of the students are there. Rajat is also seen.
Yes.
I will say.
I think, so just 1 minute, sir. I think we have Dr. Abhijit, our first expert, joining in. So we welcome
fine.
Dr. Abhijit, sir. Hello, Dr. Abhijit, sir.
Yeah. Good evening. Thank you.
Yeah. So yes, welcome to this session of e-Gurukul, sir. Dr. Abhijit is a pediatric neurologist. He's the director of Blooming Brain Center at Pune currently. Sir has had multiple posts prior. He's had fellowship in pediatric neurology and epilepsy under guidance of Dr. Udani, sir. He's been working as clinical associate in pediatric neurology. Then he has done his clinical neurophysiology and epilepsy training. He has been a visiting consultant at Sahyadri Multispeciality Hospital in Pune. He's also a consultant pediatric neurology and epilepsy at KM Hospital and Research Center, Pune. Sir holds several memberships of various other, and he's had multiple publications, and he has his keen interest in pediatric neurology, acute neurology, movement disorders, neuroimmunology, and pediatric epilepsy. So we welcome you, sir. So we have our PG, Dr. Rahul, presenting a case today, and we have Dr. Baldev, sir, also as one of our renowned teachers who is also there for these sessions. Thank you, sir.
Yeah.
Dr. Rahul, I think you can start sharing the screen.
Yes.
And start the history part. Sorry, my throat is probably not that good, but I'm sure that we'll be able to talk.
Good evening, respected dignitaries.
Rahul, can you make it full screen?
Yes, sir. Sorry. Yeah. Yes, sir.
Yes, fine.
Today I am presenting a CNS case. Patient's name is Lavanya Kumari, 2-year-old female, Hindu by religion, native of Jharkhand and resident of Goa now, presently staying in Goa. First child born out of non-consanguineous marriage. History is given by the parent, is reliable and adequate. Date of admission was 6/8/2024, was admitted for evaluation, and I examined the child on 8th August 2024. The chief complaints the mother came with specifically were delayed attainment of milestones since early infancy and intermittent tightening of both upper limbs and lower limbs since last 6 months. I would like to start the history from antenatal history because the events are there, so the flow will be proper. So antenatal history, the mother was 23-year-old with regular antenatal care. First time as the child was conceived spontaneously. Only one USG was done, sonography, which is mostly the anomaly scan because the papers are not, the documents were not available, which was normal. And the pregnancy was confirmed by urine pregnancy test at 1.5 months. Booked an immunized case, folic acid supplementation were taken. Not preconceptionally, but during the first trimester, and no history of any fever with rash, excessive vomiting, or radiation exposure. No history of any burning micturition during the first trimester. Second trimester, quickening felt at 20 weeks of gestation. Oral iron and calcium supplements were taken adequately. No history suggestive of any pregnancy-induced hypertension, preeclampsia, or bleeding PV or leaking PV during the second trimester. Third trimester, no history of any decreased or increased fetal movements, no history of bleeding or spotting PV, abdominal pain or fever. The mother had onset of pain and was admitted in the local primary health center. Total weight gain of the mother during the pregnancy was approximately 12 kg. Natal history, leaking PV was for about 4 hours before delivery, normal vaginal delivery. The documents of the resuscitation procedures were not available with the mother, but at birth, the mother is saying that the child had a weak cry and some resuscitative measures were done on the child and then was on O2 for unspecified days. Details are not known. And birth weight of the child was 3 kgs. Postnatally, but the child was initiated on at 2 hours of birth only. The baby was kept at mother's side, was taking breastfeeds adequately. No history of any lethargy, seizures, poor feeding, or fast breathing was noted. Baby was discharged on third neonatal day. At home, baby was taking breastfeed well. But on the 7th and 8th neonatal day, the mother noticed that the baby was looking a little bit jaundiced. So because of this, she went to a local ASHA. And there, the ASHA advised her only to expose the child to the sunlight. But mother's blood group is not available. It is lost. Now, I would like to start with the present history.
Anyway, can you stop sharing for a while?
Yes.
Whatever information I think you have provided, let us go into the details of it. I think any question from other students? Any information which you want from Dr. Rahul? Or any clarification? I request all other students to be active in the participation. Or are you happy with Dr. Rahul, what he said? Or you have some incomplete information or some doubts which requires a clarification? Anything, Dr. Rishi? Okay, you are happy. I think he must be your colleague. It's commonly, naturally. We should not create the problem with our colleague.
They don't want to create issues with their colleague.
What is my question, Dr. Rahul, to you?
Yes, sir.
You said it's a book case. What do you mean by the book case?
Book case is a total of 4 visits the mother should have to a doctor, basically.
Right.
So total 4 visits that mother should have to a doctor for examination.
So I think we hope that once you mention the book case, that is minimum at least 4 visits by the medical person is expected. Am I right?
Yes.
Now on other side, you say that the blood group of the mother is not known.
No, sir, not the thing was that not known by the mother doesn't know the blood group, and I don't know because the papers are not available.
Was it done?
Yeah, it was done. All the tests as well as the blood group, all the blood tests were done is the claim of the mother.
Okay.
Actually, the documents are not available. That's why I as well as the mother don't know the blood.
Okay. Second point, you said weak cry. What do you mean by the weak cry? How will you interpret it? I think before you answer, let me ask the other students. Nishi, suppose he said weak cry. How will you interpret it? Please unmute yourself. You are muted.
So weak cry meaning child's efforts, child must have not been vigorous and efforts might not have been like that of a normal child.
Rajat, what will be your interpretation?
So it might be a part of delayed adaptation accompanying that.
Perinatal depression.
Rahul, what exactly you have derived the meaning?
So, I feel, sir, it is because of the delayed transition from the intrauterine to external. Basically, a perinatal depression kind of a picture with the child head post-delivery, which the mother might have noticed. So that's the only thing.
You consider it as a part of birth asphyxia?
Birth.
How will you interpret from this? Because ultimately, you know, all these informations we want to translate it. That is there any possibility of encephalopathy?
Yes, sir. There is a possibility. The insult might even be perinatal asphyxia. It can also be, and it can be perinatal depression also. But the perinatal asphyxia mostly is a little bit more severe compared to the depression. So the next postnatal history of the child being at mother's side at 2 hours of life is I had a doubt. So that's why I said it is a
I think
perinatal.
my question to all other students who is able to answer, how will you define this neonatal encephalopathy from the history point of view? What information you will gather, which will indirectly indicate that, yes, this indicates encephalopathy. Because, you know, ultimately our point in this, at the time of birth, we want to know that is there any history or any point which indicates that there is encephalopathy, and because we try to understand that whatever this damage to the brain, is it really part of this neuroencephalopathy or not? And therefore, this very vital point that we should be able to derive this information. So how will you say that, yes, this indicates neonatal encephalopathy?
First thing is the child post-delivery had a decreased feeding, decreased activity. Furthermore, had seizures post-delivery. That is one of the very strong features of encephalopathy. Then seizures, decreased activity, decreased
You know,
feeding.
seizures can be later on due to hypocalcemia also.
Yeah, within 6 hours, sir. It is within
Okay.
6 hours of birth. It is more significant.
Yeah.
Basically telling that this child has had a insult of during the perinatal as well as can be antenatal cause also.
But suppose some baby develop the seizures late, then it excludes this encephalopathy.
No, sir, but less likely compared to within 6 hours. It can be,
Okay.
we have to rule out the secondary causes also if after 6 hours, even within 6 hours, but less likely if it is more than 6 hours.
Anybody else would like to take this issue? That how you will interpret? Rajat?
So decreased activity, then there might be tone changes like hypotonia, feeding issues, and or if there is a requirement of extensive resuscitation at the time of birth.
Okay. I think fairly good points, but let me convey, and this is very important for all of us. Commonly what happens at the time of birth, baby is delivered, suppose absolutely normal, favorable situation. As the baby comes out, baby will cry, his respiration is established, right? Oxygenation is there, and baby becomes, I will say, independent from this oxygenation and other points of view. You must have seen the normal babies. Immediately they look at surroundings after this crying and initial point, because you know it is a stress to the baby also. Delivery is a stress to the mother, but stress to the baby also. Afterwards, baby goes to sleep. And after some time, baby gets up, becomes active, alert, looking fresh, looking surroundings, searching mother or even her breast, and starts to take the breastfeeding. And even after taking the breastfeeding remains playful for some time, active baby, goes to the sleep, again gets up to take the breastfeeding. I think this is normal activity of the baby after the birth. Am I right?
Yes.
But what happens in a case of encephalopathy? Whether baby cried immediately or didn't cry is a different story. Not necessarily always history of delayed cry should be there. Many a times baby delayed cry, but maybe even absolutely normal. And no history of delayed cry, but still that is resulted in the brain damage and cerebral palsy. I think several times you must have come across this type of the story. So probably something else is more required for us. And that you can ask what was the activity of the baby after the birth. Of course, some of the points all of you have mentioned, very important. Even the cry, later on, what was the activity of the baby? Many times mother will say that afterwards baby is sleeping, does not get up, not taking feeds when you go in the postnatal round. Or baby remains lethargic. Or many a time the baby, on the contrary, common story that baby becomes irritable, excessive crying, not taking feeds. And even sometimes what you added later on may go for even the seizures and problems and complications. At the same time, if there is history of an ICU admission, which requires the oxygenation or ventilatory support or requires some management for the seizures, if these histories are there, certainly it makes a point clear that there was the encephalopathy. So I think these are the points which we should go in the details to derive the history of encephalopathy, the newborn, rather than just cried and didn't cry. So I think here with the weak cry, okay, we noted that some problem was there, how much its gravity of the problem, importance, that we should go in the details of all these histories. Then I think that will be more reliable. One more point, Dr. Rao, you mentioned there is no increase or decrease movement, fetal movement in utero. Anybody will give the example, one example for decreased movement, Dr. Viraj? And one example for increased movement, fetal movement. Intrauterine, we are talking.
So if there is any intrauterine asphyxia, child could have decreased fetal movement.
Okay. And increased movement?
If the child is having intrauterine seizures, it could manifest as increased fetal movement.
Okay. Intrauterine seizures due to what?
Intrauterine seizures could be one, it could be because of hypoxia also, or maybe intrinsic neurological problem in the child.
Okay, anybody else?
The non-ketotic hyperglycemia is one of the cause, which because of the intrinsic accumulation of glycine crystals, usually the child intrauterine only starts getting seizures. So one of the causes that.
Okay.
So non-ketotic hyperglycemia and other like Dr. Viral said, other causes like intrinsic brain anomalies like lissencephaly can also in certain condition can cause, and accumulation disorders like ceramide accumulation disorders like Krabbe's disease and all also can cause intrauterine
I think you must be knowing that.
So because of that, I had a decrease in
you must be aware that most of these metabolic disorders, inborn error of metabolism, most of the times when the baby is in utero,
a little bit of net issues 2 minutes.
Baby is in utero, probably manifestations are usually not there. Because what are the metabolites needs getting from the mother, and what are the harmful metabolites are managed by the placenta. Most of the times, not every situation. So most of the inborn error of metabolism, what story usually we get it, that at the time of birth, baby was fine. later on started the story. That is most common. Barring few of conditions, of course, it is there. The classical example to remember, suppose somebody asks in the exam, that decreased movements may be in a case of spinomuscular atrophy. That is the most common story. And that will be quite convincing. And what even Dr. Viraj said, I agree that the fetal convergence, but fetal convergence also is an etiology based to remember, not so common, but paradoxic deficiency. That can present as the fetal seizures in utero, which is known. And of course, some other conditions are also there. And I think common, which if somebody is asking the exam point of view, I'm suggesting you that very easily, very common and convincing reasons you can mention. So I think these are the points from the history what we wanted to know or clarify. I think now later on what the Rahul provides the information or present complaint, again will be back. I think before we go further, let us take a word from experts. Dr. Abhijit is there. I think Dr. Harsh is there.
Yes,
Dr.
sir.
Abhijit.
Yes, Dr. Yeah, just 1 minute. Dr. Harsh Patel, our second expert also, I think, had joined in. Welcome, Dr. Harsh Patel, sir.
Yeah. Evening.
Yeah.
Thank you.
Yeah. Dr. Harsh.
I think Dr. Vaishali, can I take the liberty?
Yes, sir.
Dr. Harsh
Yes,
does
sir.
not require the introduction.
Yes,
I think
sir.
he is known to all these groups multiple times. He has helped us as an expert. Dr. Harsh, I'm taking the liberty to save the time. I'm sure that now you don't require this introduction.
Yes, sir. Yes. Thank you, sir.
Yeah. I think before we go further, a word from Dr. Harsh and Dr. Abhijit, whatever we have discussed. I hope that they were there. Dr. Abhijit, can you take it? And then Dr. Harsh.
So, I mean, really good elaboration by Dr. Baldev, of course, about the neonatal encephalopathy. And of course, these practical points are very important because what happens in day-to-day life is we just go by the virtue of not cried immediately after birth and what is the NICU discharge card is saying. But the real practice and the history taking, which is the skill of the kind of a clinician. So there is really important thing. So sir has elaborated really very well on this neonatal encephalopathy. But before that, I would elaborate a couple of the ANC and the natal facts as well.
Yes, sir.
So when we say there is no history suggestion of GDM, PH and all these things, but definitely we need to kind of, especially when we're looking at something which may be around perinatal or antenatal in origin, we need to go in depth and ask those kind of a very pro questions about it. So definitely, of course, I mean, mother, I mean, you need to ask, I mean, of course, she was primary, she was like this thing. So definitely you need to get into labor details for sure. Because see, there is nothing very convincing at the postnatal period apart from the week where that baby is like getting into this kind of a developmental issues. So definitely, by and large, we know what primary goes through as the first, second, and third stage of labor. Third stage, we are not really keen on. But for first and second stage, so from the starting of the labor pain till the leaking of the membranes and kind of a leaking PV, and from that crowning till the baby is getting out. So when we know the time is a little more, then we definitely kind of expect some kind of intrauterine hypoxia. The hypoxia is certainly, even the baby may not require postnatal, lots of resuscitation and care. And definitely, majority places, the parents and the mother, everybody is kind of a keen. So you can ask the intrapartum monitoring was done, where there's been told that the fetal drops were there, instrumental delivery is there or not there. And in antenatal, definitely we need to precisely ask, especially last scan, if the Doppler was done, because there is some suspicion of kind of fetal growth retardation, oligohydramnios, Doppler showing reversal of flow and all these things. This itself will tell us that fetal was in little jeopardy. So those things we should be really kind of positively asking the parents about this and then taking the things from there. And again, I would say a mother would or a relative who's attending the, delivery and all these things would know this kind of detail. Again, one more thing is we should ask the EDD because the gestation, we should kind of make it really sure what was the gestation age, because that is something the lady would definitely would know, the EDD. And then from the date of birth, you should approximately calculate your gestational age and the weight, and then you say whether it's SGA, AGA, or LGA baby. Yeah, I think I'll ask Harsh to take over from here.
Yes,
Thank you, Dr. Abhijit. So, yes, I think you have covered most of the topics. And Dr. Sir, Baldev sir has made a very important topic to a point that we
Sure.
should definitely differentiate between the delayed cry and neonatal encephalopathy. So encephalopathy is a obvious, or we can say that it's a more gloomy presentation. So we have to have some more data apart from delayed cry to label this as a neonatal encephalopathy. And definitely, so the perinatal factors, antenatal, and the natal factors all are very important. And the onset of encephalopathy is also very helpful. So it by just birth, within few hours of the birth, or how many hours of the birth the encephalopathy sign appears. That way also we can help us to narrow down the probable etiology. And as far as neonatal seizures, fetal intrapartum or fetal seizures is concerned, the most common cause, as sir has already mentioned, is a pyridoxine deficiency or pyridoxal 5-phosphate deficiency. Usually, lissencephaly doesn't have a intrauterine seizures, as far as I know. The other causes are could be the folinic acid response to epilepsies, and they are very rare causes of the intrapartum seizures. But they are not the just increased movement; they are the bouts of increased movement. So, paroxysmal increased movements are very important to differentiate between the just increased movements, or there is a substrates of infantile or the antenatal seizures. That is we can just ask the mother to ascertain whether it is there is a repeated or very short duration of increased bouts of increased movements is there or not. Thank you.
Very good. I think good informations and which we can note it and please keep in mind. Now we can take it further. History part.
Yes. History of delay in attainment of milestone was present since infancy. There was partial head holding and cooing, which was attained at 1 year of age, and inability to roll over still present. Cannot sit with support, and was able to feast till 1.5 years of age. Opening and closing of hands has been started since 1 year, 6 months, and inability to play with hands in the midline or cannot reach out for objects. Visual tracking is also inconsistent, but turns head to loud sound. Cooing since around 1 year of age, which has not yet attained the delivery of monosyllables. Child has started to smile at mother and started recognizing the mother at 6 months of age. Child started to have stranger anxiety and approximately around 6 months of age and does not wave bye-bye or interact with the parents. Child doesn't indicate for foods or toilet. So developmental quotient, your gross motor comes 16, fine motor 11, language 12, and social is 12. So there is a global developmental delay in the child. History, at 6 to 7 months of age, the child was noted to have episodes of abnormal tightening of bilateral upper limbs and lower limbs associated with arching of back, which used to last, according to mother, for 30 seconds. The patient had a total of 10 to 15 episodes in a day, which is not associated with any loss of consciousness or non-responsiveness to the mother. No history of variation with the time of day. These episodes were not noticed during sleep, not associated with fever. This episode frequency has decreased since 1 year of age. At 1 year of age, child was noted to have abnormal writhing movements of bilateral upper limbs, which were paroxysmal and which had a fixed posture and used to last for about 1 minute and disappear. The movements were not present during sleep. Child also had history of episodes of head drops, which were noticed since 1 year of age. The episodes are also sporadic, but don't happen in clusters and not associated with any decrease in the movements of limb. But these all movements were not associated with any loss of consciousness or non-responsiveness to the mother. No history of noticing any association of sleep of the head drops. History of noticing excessive crying and irritability since early childhood only. No history suggestive of any other cranial nerve deficit. History of noticing tightness of limbs and difficulty in dressing of the child is present. The mother complains that the child is excessively tight, and also there is difficulty in wearing the diapers since early infancy. No history of sleeping of the child from the grasp. History of sleep disturbances are present since infancy in form of taking long time to sleep and multiple frequent awakenings at night. Child also has history of hard stools every 2 to 3 days. No history of any abnormal smelling of the urine. No history of any difficulty in moving of any one of the joints. No history of any bed sores. No history of any regression of milestone present. Feeding history. Mother complains of difficulty in feeding the child because of his excessive tightness. One thing, the child is fed by a spoon or directly, usually chews and swallows, but regurgitate the feeds intermittently and usually takes very less amount of feed. So the mother has to take effort and give more frequently. Treatment history. The child, because of the abnormal movements we started 6 to 7 months back, the child was taken to a local doctor who had started the child on levetiracetam and baclofen. EEG was done during this visit, which was a normal sleep EEG. MRI done, which I will discuss later. Diet history. Patient was exclusively breastfed for 6 months and weaning initiated at 6 months. Predominantly a vegetarian diet. Diet chart is this. Total calories which the child is receiving is 700 kilocalories and 11.2 grams of protein, which is deficit by 500 kilocalories and 0.8 grams protein. Immunization history. The child is immunized for age. Last vaccine taken at 1 year, 5 months of age. One episode of breath holding spell is present with cyanosis, but doesn't recall the vaccine, and immunization card is not available. Family history. The only child, no history of any developmental delay in the family. No history of any seizures in the family. No history of any repeated abortions in the family. Socio-economic status. Father is a daily wage worker. Mother is a homemaker. Lives for rent in a pakka house with single bedroom and kitchen. Separate toilet facilities are available. Source of water is from government. Modified Kupuswami classification. It is coming to upper lower class. The score was coming to 7. So summary.
Okay, can you just stop sharing?
Yes.
I think a lot many information here provided. Let us try to understand one by one. Number one, I think so many students are there, but their video is off. I think it's not fair. Then we cannot discuss, we cannot learn. The active participation is very important. We should not be afraid of our wrong answer or something probably we have not understood. For that reason, we are here. And I'm also not afraid because 2 more experts are there. So suppose something is wrong, they will correct us. So please come on. Let us focus regarding the development, because Rahul has mainly discussed the points related to the development. Who will take the initiation? That what information Rahul has provided, how you are interpreting. He has told so many things. I'm sure all of you must have attended. Now let us go for the interpretation. Who will take the initiation? Whatever you have understood, you can make the comment regarding this developmental history. Come on. I want that at this voluntary participation. Somebody should raise the hand. Anybody?
So all the developmental milestones are delayed, sir, in the gross motor.
Very good, Viraj. Let us start it.
So in gross motor, fine motor, language as well as social, all the area domain, the milestones are delayed. But there is no regression of the milestones, as per the history.
I think for the sake of our basic understanding, let me take some time. Number one, always how we should approach any developmental problem. First, ask the questions to yourself. Whether development is normal or abnormal. I think here it is quite obvious that yes, development is abnormal. The next question should be, what is the abnormality? Dr. Viraj made the statement that it's a delayed development. Okay, fine. I think Rahul has made these points very obvious, the delayed development. Further question should be delayed, restricted to any certain domains or generalized. And from that you can say that it is a global delayed development or very specific. Suppose here, if I, for the sake of our learning, if I take you some of the points that may not be in this patient, but some other child, that is the gross motor is more affected, gross or fine motor, but speech and personal social almost normal, or maybe the borderline. What will be our interpretation? Or which conditions may present in this way? That motor part is affected, but language and personal social almost normal or very borderline affected, which you may consider as normal.
Muscular dystrophies or cerebral palsy can present.
Conditions like
Dr. Chandan, I think your net is
also
just carry on.
cases of motor weaknesses along with the cases like muscular atrophy, SMAs.
Okay. I think
Whom
one
may have near normal
Dr. Chandan, I think there is some net issue on your part. You are not clear. And second thing, not many background noises are there. Anyway, you can try to adjust it. Meanwhile, what Rajat and even the Chandan both have mentioned, sorry, that yes, pseudohypertrophic muscular dystrophy can present in this way. But any very common condition.
Cerebral palsy can also.
Yeah, CP only.
The motor will be more.
Chandan, you can manage your, I will say, because you are not clearly heard and not many noises, so your response is not clear, please. Yes, Nishi?
So severe acute malnutrition, gross motor development can be affected.
Yeah, I think very common you must be getting in your OPD even, or even the indoor patients with severe acute malnutrition. Their motor part is more affected. If I give you some other example, motor part is normal, absolutely normal, but language is mainly affected. And even social aspect is more affected.
Autism spectrum.
Yeah, I think this is very common scenario.
Autism spectrum.
And I think it is our daily, never common practice. Therefore, I wanted to bring this point to your notice. Probably, maybe, obviously, knowing to, but I thought that let us go it. So this, which type of the problem it is. Now, next question, even you should go. What is this deviation and what is the delay? What is this? Is there any difference? Dissociation of the milestone and deviation of the milestone. What do you mean by it?
So dissociation, the developmental quotients will be different in the language and the so different domains will have the different stages of development.
Right, that is dissociation. Clear. Okay. Then what do you mean by the deviation of the development?
Sequence of development of the milestones differs. There is a deviation from the normal sequence of development of milestones.
Very good. I think Nishi is very clear. I think one principle in the development all of us should know, that in the development there can be the variation in every baby, every child, even physiologically, not necessarily pathological. Sit-in can be at 6 months, sometimes even 8 months, but it's normal. But the sequence is fixed. That the first child should be able to raise the head, then sitting, then crawling and walking. That time duration, time frame can be variable, but the sequence should be the same. That's the principle of development. But suppose the sequence is changed, what Dr. Mishi made, then I'm sure that is a deviation. And then Nishi, what does it indicate the deviation? Which conditions may present with a deviation of the milestone?
Sir, in CP, there can be a deviation, like if there is handedness, hand preference comes earlier, like before 2 years. So that is a deviation.
Okay, but which conditions may present?
Hemiplegic CP.
Suppose you decided, yes, it is deviation.
CP, yeah. In cerebral palsy is one condition.
Most common cerebral palsy.
Spastic hemiplegic.
If you go in the details, any variety, but cerebral palsy. Of course, you can go in the details to define this type or variety of the cerebral palsy. So I think these are the points which are very important in our daily practice as a general pediatrician. And if you're able to understand and interpret, then probably further you can work. And of course, regression of milestone is very important. What is the regression of milestone and in which disorders will get this regression of milestone?
Regression of milestones are the ones.
Loss of acquired milestones.
Very good. That already may be achieved, but later on gradually losing. That is the regression of milestone. And can you name some conditions, common conditions in the pediatric practice?
Rett
The
syndrome.
Rett syndrome can present.
Excellent. Rett
I
syndrome.
think
Infantile spasms and
as a whole, you can say degenerative disorders,
Mm.
CNS degenerative disorders, and of course some syndromic conditions. But even one more condition which I want to bring to your notice, what is one more common nutritional condition?
severe acute
malnutrition
Where,
SACD
where is
again.
very specific variety of, I will say, nutritional problem. Just, yes, Dr. Nehal has mentioned. You must,
SACD can. Subacute combined.
you must have seen the patients of infantile tremor syndrome.
Vitamin B12 deficiency.
Right, B12 deficiency common. And they present, and here somehow, why I'm discussing this condition, that if you treat it even, it is treatable. In due course of time, the baby becomes normal. So I think being general pediatrician, we should be able to identify the condition, to interpret it and to manage so that further damage can be prevented. So I think developmental history, so many things are there, and nowadays people are focusing even to be specialized in that field. And for the pediatrician, all of us know that the growth, development, nutrition, immunization, these are the very specific aspects because we are dealing with the growing children. Probably these aspects may not be much important in the adults, but of course in the pediatric practice, and therefore we should be knowing more details of these fields. That was my idea, because you have brought this problem with the development. So I thought that let me share so that it will be useful in other children also. Okay, so here what Rahul has made, that development is grossly delayed. Then you should know, you should go for calculation of developmental quotient, which he has done. Up to whatever Dookie is reliable. Up to what age? At any age you will go for DQ?
2 years.
Or is there any time frame?
5 years of age.
Yes, Rajat?
So till 5 years of age.
Yeah, 5 years. And later on?
Later on, until IQ will be.
Yeah, you can go for the IQ. And IQ assessment is little bit complex phenomena, which requires special training of the person. Some of the even psychologists and others, they are able to do. But the point is, I think we should know that how we should go further. So here, it's a global delayed development. It's a gross delayed development. Now, second aspect, what he has made in the history, the child is having in between excessive crying or irritability, tightening of the limbs and arching. During that time, there is no loss of even the consciousness, what he has mentioned. It is in the form of the episodic, not continuously. In between, child becomes normal. Nishi, what does it indicate? What type of the problem which he has described? What do you call it?
So dystonia.
Very good. Very good. I think from this description, we understand that the child is having the dystonic, these episodes. And once you know, ultimately our idea why we are discussing all the things, we want to decide the anatomy, that which part of the brain is damaged. First, we want to decide the anatomy. And second, then we'll try to think what is the possible pathology, that why it has caused the damage to this particular part of the brain. And if it is possible from the history, we'll try to derive what is the etiology. So I think for the whole exercise, these are our goals. And having these ideas, we will try to gather the information. And then we'll go for the analysis and try to come to the conclusion. I think that is the beauty of this history part. And I'm sure in the presence of two eminent neurologists, I'm making the statement. I think frequently Dr. Brajesh Sudani tells that more than 80% diagnosis in neurological case should be obvious from the history part only, provided you have derived the history appropriately. From the history, probably examination is just for confirmation of your finding, that what I'm expecting is present or something else. Very few specific investigations for further confirmation and planning of the management. So I think being postgraduate students, we should have the clear idea that what I want to discuss. Having this, suppose if you say that this is dystonia, then which part of the brain is affected likely?
Subcortical basal ganglia.
Basal ganglia is also, you know, the very wide.
Putamen.
Putamen is internal.
And you know that each nucleus in the basal ganglia is having the very specific physiological function. And if they are damaged, very specific manifestations. And I think from that point of view, we can try to derive them. One more point, what he said, head drop. Head drop, what does it indicate? Dr. Rahul, what is your idea?
Head drop, sir. I feel it is a sudden loss of tone which is happening during because it is kind of dystonia only. So I'm attributing it to dystonia, which is sudden loss of tone, which is causing the head drop, which is interpreted by the mother as a head drop.
Is there any other variety of the epilepsy?
Yeah, atonic seizures and infantile spasm very rarely. Yeah, but infantile spasm also can be.
It may not be in this patient or here in this patient, they're different story, but it is known. So that we can keep in mind. One more point you have mentioned, breath holding span. Any comment from other students regarding your colleague, Rahul? He said history of breath holding span. How will you take it? I think Dr. Virat name is there and two friends are attending. So please come on. He said history of breath holding span. What is your comment on this history? That means, do you agree or something else? Or breathing spell? How will you explain? Anybody? I think Chandan is trying, but he has some problem of the net. You can change, I think, place, Chanda. You can find out some place where probably this problem can be avoided. Anybody? You see, how will you take it? Breathing spell?
Sir, a behavioral issue as a behavioral issue having, or I-
So can be episode of means prolonged dystonia, which can have must have happened because of irritability, like status dystonicus like condition. Because
Okay.
continuously the child might have just had dystonia for a long time, and she might have interpreted it as.
I think interpretation is by Dr. Rahul, not by the mother. I'm sure mother has not told that this is breathholding spell. Am I right?
Yeah, yes, sir.
Whether it was
Yeah.
provoked or unprovoked.
But I think now what you are probably changing or mentioning the statement, already baby is damaged by the brain. And then whatever the manifestations, I will try to explain based on that, rather than the different etiology. That for that episode, I would like to consider that is it a part of this pathology? Most commonly, yes. And that can be many, occasionally maybe the manifestation of seizures, maybe even due to the severe dystonia, or some even occasionally feeding problem, and even the hypoxemia, something like that, rather than to call it breathing spell in such a patient. So these are the, I think, points which you can. Now, before we go further, I'm sure that experts will be very keen to add. Dr. Abhijit and Dr. Harsh, can you take it? Whatever Dr. Rahul has discussed, can you add some more information? Dr. Abhijit, can you take it?
Yeah, I thought let Harsh take over and I'll kind of add. Do you want me
Okay,
to-
Dr. Harsh, you can take. I hope Dr. Harsh is there.
Yes, sir. Yeah.
Harsh,
So,
we have tried to understand. You can add, I will say, make it more clear.
yes, sure. Just I would like to dig out some more details about the description of the head drops and the breath holding spell that I have mentioned. So, what exactly mother has described? I would just like to know that. Yeah.
That's a good question.
Yeah. So the mother has described it as when the child is usually very irritable, or when some other person is around her, like some stranger type of anxiety is there. Suddenly, when she lifts it up, the head just flexes and he just loses tone. But when the mother asks means tries to get a response from the child becomes okay. So it is very momentary, like around 1 to 2 seconds she's saying the episode lasts, and then it becomes okay. The child becomes fine. It is just
Every
like
time it is with this precipitating factor. So, if there is a stranger, something, or some anxiety like that, then only it happens. Otherwise, it won't happen.
no, sir. No, sir. Means the inciting factor is either the child is uncomfortable, maybe this someone else like is coming. Mostly she's saying aunt, or the child will just the head will flex. But when the mother will try to get response, the child will respond. Means look at the mother. That is all.
Fine. And what description about the breath holding spell by the mother?
Breath holding spell, the mother said that the child was continuously after the immunization. The immunization is not clear, but after the immunization, the child was continuously crying, and after the after continuous crying, the child just stopped breathing for prolonged around what she's saying, around 10 to 12 seconds she's saying, and then became blue. After that, this doctor managed to put the hand in the mouth, and then the child became okay. This is the history exactly from her. This.
So there is only one episode. After
Yeah, only one
immunization.
episode, which was inciting factor was immunization.
Understood. Fine. Yeah.
Yeah.
So yeah, it fits with this description of the breath holding spell. So yes, whatever you narrate the history was descriptive and nice. So it was showing that there is a delay affecting almost all the domains. There is a hypotonia as he is not getting any motor milestone also along with age progresses. And there is a paroxysmal episodes of arching also, arching of the back and this thing. So that is a suggestive of dystonia.
Yes.
As far as the your description of the head drops is concerned, I think I would like to prefer to mention the whatever the mother had described rather than terming them as a head drops because it denotes a very specific meaning. So when we describing the head drops, it's usually either we are dealing with either the epileptic or the tonic spasm. So that is more definitive or more indicative word rather than the loose term. So we'll describe when we are not sure that either it is epileptic or non-epileptic, rather to better to describe whatever the mother has described in the similar word. And that allow with other information, we can interpret that particular symptom as isolated or along with other, whatever the symptomatology is presented to us. So we can combine the summary. Okay, so always we need to, I would like to add the adjective whenever I dealing with any neurological case. So whatever the issue is that the onset, so whether it is acute, hyperacute, chronic or static, whether it is progressive or not progressive, whether it is affecting whatever the domains, whether motor or other domains, or whether there is a presence of seizures or not. So all these things, once you label them step by step, it helps you to narrow down your possibility. It helps you to make a one syndromic diagnosis also, what exactly presented to you, and that helps us to narrow down the etiological diagnosis also. So that way helps you to clear your thought process also. So rather than terming the each and every symptoms, just make them whatever the mother has presented to you, and then you can definitely interpret once you are very confident. If you are not confident, just leave them as it is. Description but given by the mother, and then narrate with all the other symptoms, whether it is fitting into that particular ongoing process or not. So whatever the presentation you have done, the child has a global developmental delay, static pathophysiology. He has paroxysmal events of dystonia. There is a intermittent head, there is a in between head instability or is not holding the head, and suddenly he flexes the heads, but it less likely of epileptic nature. And there is a presence of breath holding spell, which is also it's not that much. Very we can say it's not a very prominent symptom, but definitely the underlying whatever the developmental delay and this dystonia, these are to be the main we can say handles for which we can narrow down the or we can localize the localization pathophysiology and everything should be focused upon. So whenever you are summarizing the history, these are the major handles you should take care of it, and you can put it in a along with certain adjectives which help you to clear your thought process. Yeah, thank you. Dr. Abhijit, yeah, please, you can add.
So, I mean, Harsh has covered majority of this, but definitely, I mean, I would segregate those in couple of domains. So you would segregate it as like motor, social, then few of your episode, then typically what you ask for the static encephalopathy, all your feeding, sleep, constipation, and all these things. Definitely, because I mean, sir mentioned my mentor, Dr. Udani. So definitely I would take it from there. And always you should ask till when the baby was looked okay. Because was this concern of delayed development was made by clinical practitioner or was it the parental concern? So everything of yours would have started around 1 year of age, right? So
Yes.
definitely you should be asking what is the thing happening till 1 year. So these are the things which are really obvious, which kind of scared you. Okay, these were dystonic spells, there were kind of tightening of limbs, there was like no kind of, he was started unfisting his limb and all these things. But what was his early infantile milestones or what was his early infantile behavior, which would give me little clues? Because now see here on the background of your normal perinatal, the suspicious weak cry, no consanguinity, nothing, and everything kind of geared up really very well after 1 year, isn't it? So till then, I mean, was baby hypotonic? Was baby was really, I mean, difficult to carry? Was kind of changing and kind of holding a baby? So basically, in on historical, you should ask whether it was central hypotonia and appendicular hypertonia, or it was very hypotonic baby otherwise, and what was it? And especially little more on bulbar issues. So how much time it would take for baby to feed? Were there any recurrent aspirations were there or not there? Whether there is, I mean, choking during feeding were there or not there? So those things will be little giving more clue. Now coming to this episode when I'm talking to. So what is your general interpretation about this? So on the background, if you're kind of a, I would say little discrepant kind of a motor, gross motor little more than a fine motor than a social, because he said the patient has change in anxiety and he was kind of making an eye contact and all these things. Little discrepant kind of a, I mean, global developmental delay, but even some domains are okay. And again, were there any subtle regression or some static thing, or the milestones were picking up over time, or few of the milestones were reducing? Because definitely we know a couple of kind of epileptic encephalopathic spasm, LGS drop attacks. There we see, I mean, the motor milestone may be static. There could be sensory issues. For that baby may not be start doing anything, but definitely, I mean, and again, cognitively, even baby will get those acquired autistic features, right? So those were there or not there. And second thing is these kind of a dystonic spells where they were myoclonus or exaggerated startles, or they were dystonic spells. So that is something, I mean, you should be always making a differential into. So different, typically, I mean, startle and something I would get on history differently. We am kind of seeing neurology in and out. That may be reason we are looking at it very nichely. So one more point, I mean, of obvious head size. When you say the kind of a head is obviously looking, I mean, if at all on inquiry, if you say the head is may not be, I mean, looking small or head is big, what difference does it make if at all you have this kind of a startle or dystonic spell or myoclonus? If you have big head, do you have any differential in your charts?
Big head, sir, then we will consider macrocephalic condition like Canavan's and Alexander's.
No, with exaggerated startle or with kind of those dystonic spell. Anybody? So what is cherry red myoclonus? So it's Tay-Sachs basically. So they will have kind of a big head and they'll keep on startling on there. They will have GDD, of course, may not be this dystonic and spastic severely, but this is again one of the differential you look into. Again, as you said, the tone and everything was kind of a better when baby was sleeping, right?
Yeah.
So it's more of an extra pyramidal. And then, I mean, how the mother used to carry the baby. So carrying the baby in a kind of a playful mode and eating mode was easy, then again it would tell is more of an extra pyramid as well as, I mean, less of kind of pyramid. So if it was just throughout this spastic or throughout the, I mean, stiff versus some action induced thing. So definitely little more of basal ganglia versus, I mean, white matter tracts and this thing. And this I think we will cover in our examination.
I think Dr. Rahul, initially the development was normal according to you?
No, sir. Means the child did not attain only, sir. She was mostly
Yeah, I think early milestones were also affected.
Like she started. She's still not started rolling over.
Yeah, even
Means the
sitting. I think you said just 2 years sitting with support even. Am I right?
No, sir. Sitting with support. She's not sitting
Not
with support.
attained yet. Yeah.
Yeah,
Not
still,
rollover,
still, still not attained.
Still not. She is not rolling over.
So I think milestones development what affected is from the very beginning. I think
very beginning.
From the beginning.
It's not after certain age also.
No, it is from infancy. Means in the first year of life.
Yeah, from I think rather than first year, from the beginning we can say. You know, it makes
so she
difference.
never attained anything rather. Yeah, that's what I mean.
Exactly.
Yeah, never attained.
Never attain,
Yeah.
I think.
And
So
one
it
more
makes-
little kind of, I mean, practical clue I would like to give you. I mean, definitely, well, see, when we nurse baby, you keep the baby in different postures. Definitely, what you want to do these things in your examination as a manual. So definitely, when you ask them very leading question about the manual, so if what was baby doing in prone and what was baby doing in supine. What typically happens when baby goes in prone and if at all the head holding is better.
Rajat, you can, please.
So basically on prone, if the baby is kind of holding head better, he was having more arching, he was having more kind of a steady head control. So that again gives me little more clue towards extensor tone. So that again tells me the extensor tone is better as compared to when the baby, when you're carrying the baby or when you make the baby sit. So again, this is a couple of subtle signs again kind of giving me clue to us basal ganglia pathology.
I think regarding tone also, he mentioned some of the points that mother was finding difficulty in changing the diaper and other things.
Very true.
So I think that then it favors that the baby is having the hypertonia.
Yeah, very true. And there are some scissoring kind of movements where there is
some scissoring. Even the adductors means affected.
Very true.
Very specifically, even the group of muscles.
Yeah.
I think now with all these discussions, as usual, what we say, at the end of the history, try to analyze that what is the anatomy, which part of the brain is affected. And then second, what is likely pathology? Who will take this point? In the history, what we gather the information, in short, if we say that baby had some weak cry, otherwise full term, birth weight was 3 kg. I think antenatal and perinatal period, somehow no significant incidence was noted. But later on, the development is definitely grossly delayed. And it is globally, with some of the points indicating hypertonia, dystonia, and even this breath-holding spell, what we consider head drop. We'll have to keep it that in what way we want to interpret. In such a baby, what will be the anatomy? Because he said that almost no point indicating cranial nerve involvement. No
Subcortical is involved.
Tightening of limbs, giving a suggestion of spastic in nature, which involves basically cortical, subcortical areas of brain.
Sorry, Chandan, somehow again your voice is breaking several times. Anyway, Dr. Nishi, can you take it? Then Viraj.
Sir, due to the there is hypertonia and mostly all 4 limbs are involved. Truncal involvement is also there and dystonias are there. So most likely it is cortical as well as subcortical involvement.
Okay. If, what are the points favoring the cortical involvement?
So all 4 limbs are involved with hypertonia and truncal involvement. So cortical involvement because of that.
Cannot be in a case of basal ganglia involvement?
It can be there that internal capsule part if that is involved along with the anatomy.
Nishi, what is your interpretation?
Sir, can be present.
I think what points you can make it, that's even the global delayed development. That indicates the cortical involvement. So many functions are not there, which are expected from the cortex. And very specific, probably subcortical or the basal ganglia, you can say that the dystonia and even the other features, right? So here we can make the anatomy that probably generalize, use cortical, and even the basal ganglia involvement. This is anatomy. Okay, what is likely pathology? Viraj, according to you, what is likely pathology?
Spasticity with dystonia.
It could be a
but what is the pathology? Pathology. That means
could be
what type of
hypoxic injury to the.
Sorry.
Could be a hypoxic injury to the cortex and subcortical region.
Okay. But I think there is no strong points in the history we have. But you can consider that it can be with weak cry or even sometimes without this issue also. Any other reason?
So the jaundice which was not documented, that can be a cause.
Basal ganglia.
I think somehow that part we have not discussed in details. That baby was otherwise taking the feeds appropriately within few hours of birth, what he has mentioned. Postnatally, baby was all right, even was discharged. There was no any problem. And I think after a few days, I'm not sure, after 5 or 7 days, around what was the time for the jaundice?
7 days.
8th day.
7 to 8 days.
Yeah, 7th or 8th day.
neonatal day.
The baby, and I think he said grossly, and no, even the bilirubin was not done, or you don't have the record?
No, not done, sir. The mother noticed the jaundice and had taken to Asha, where is there, and she told to just expose to sunlight and nothing else.
Okay, later
So
on
bilirubin level was
not managed at any hospital.
not managed at any hospital
Yeah,
during that time.
then
on
I
the
think
8th.
this point becomes very strong. Now at least he has no even information, group of baby, a mother even. So regarding the etiology of jaundice, it's okay. But jaundice probably must be the significant. And having this clinical picture, likely that even the bilirubin encephalopathy may be responsible for this damage. In the presence of information, because these were the strong information. Regarding asphyxia, we don't have the much information. So we can take in this way that this is likely more of the bilirubin encephalopathy. Similarly, always keep in mind, sometimes in some babies, there can be hypoglycemic encephalopathy also. So try to find out the etiology. Suppose some low birth weight baby, growth restricted baby, develops even these seizures second or third day, and the significant hypoglycemia, managed at hospital, baby fine, but later on this cerebral palsy one, in that background, that may be the hypoglycemic encephalopathy. So here, what is my point? That tried to find out that what type of encephalopathy was there. Was it hypoxic? Was it bilirubin encephalopathy? What is hypoglycemic? Sometimes even it can be due to the various regions in invalid of metabolism also, due to hyperammonemia, due to organic acidemia, so many regions. So always try to find out that what is the likely pathology. Here probably what we understand, maybe the bilirubin encephalopathy. And then what are the cause of jaundice and everything, we may try to establish if it is possible. Otherwise, this is likely. Now here, having this discussion, almost we have taken more than, I will say 60, 70, 75, 80 minutes for this history part. Who will go for the summary? Two students, I want to give the summary. And again, summary should not be the repetition of the same story, same points which we discuss. But the point is, try to give your interpretation, inference, or prepare the hypothesis that what you are thinking in this patient. Already we have discussed. But right, but it should be very, I will say 8-10 sentences in the summary. Who will take it?
Sir, this is a 2-year-old female born out of non-continuous marriage. Came with the complaints of delayed milestones and intermittent tightening with no significant antenatal history, with a birth history of weak cry and resuscitation. And postnatally, there was a history of hyperbilirubinemia, which was not evaluated. Later, there was also a history of noticing delay in the development, also associated with dystonias, and also associated with visual deficits and hearing deficits, and with disturbances in feeding like regurgitation and constipation. So this is most likely a case of static encephalopathy, mostly cerebral palsy with quadriplegia, associated with dystonias, as well as with visual deficit, hearing deficit and seizures, and also with regurgitation and constipation.
Is there any history of seizures in this patient? Dr. Rahul?
No, sir.
Yeah, Chandan, there is no seizures.
Okay, sir. With breath holding spells, which requires further evaluation. Most like anatomically, which is a quadriplegic CP with spastic in nature. Site could be most likely cortical, subcortical, and basal ganglion involvement. Pathologically, could be one could be hypoxic event or a hyperbilirubinemic event or a hypoglycemic event, which is not noted, or it could be also a metabolic or a structural malformation.
Okay. One more, Nishi. What will be your way of putting in the summary? First, unmute yourself.
So this is a 2-year-old child born of non-consanguineous marriage presented with complaints of noticing delayed development of milestones, along with some dystonic movements. Also, besides that, so child has basically there was no history of seizure, and other complications like regurgitation were present. So this looks like child is having static encephalopathy, most likely cerebral palsy, spastic in nature, and secondary to either hypoxia, or it could be because of the jaundice, which was not evaluated in the perinatal period.
Okay, fine. I think already Dr. Harsh explained us very nicely that use adjectives at multiple places. What are the disorders? Suppose if we say, is it acute, subacute, or chronic? Try to define it. Is it progressive, non-progressive? That is static. If it is progressive, again you can try to define it is slowly progressive, rapidly progressive. Further, you can take it, what is the status of the functions of the organ? And third, your associated problems or the morbidities. That will give the clear picture that what type of the disorder it is. And I think that should be applied not only the CNS, any system. And I'm sure that that will be the more clarity of the clinical application. And that will give a very clear idea to us also for further approach or further evaluation. I think here in this patient, if you see, first try to define these deficits, problems. Then try to explain the anatomy. Then the possible pathology. If we try to look at this patient, what are the problems, what we are facing? Number one, grossly, I think what was the chief complaint is the delayed development and delayed gross global delayed development. Second, it is probably non-progressive. At the same time, it indicates that yes, there is a motor deficit and even involvement of the basal ganglia. And then we have discussed from which we have decided. And of course, the child has associated problems of even the feeding problem, even the maintenance of the head, even the stranger anxiety, constipation, and so many other problems are associated. Having this clinical picture, it gives us the idea there's a static motor deficit with so many other issues. And then it is likely some variety of cerebral palsy, where the involvement of the cortex and basal ganglia is obvious. Regarding pathology, I may not give the much importance of hypoxic encephalopathy, but possible that the bilirubin encephalopathy. And having this issue now, I would like to go for further examination and evaluation. I'm sure that if we try to put in this format, most of the people will accept us. Should we go further examination, Dr. Abhijit and Dr. Harsh?
Yes, sir, we can go ahead.
Yeah, I think we can see another question. Sometimes some people will ask you, Rahul. Yes. Rahul has examined the patient. So probably Rahul should not answer. Viraj or Nishi? Nishi, what? what you are expecting on examination to this patient?
Sir, on CNS examination, while doing the motor system examination, muscle wasting will be present. Then tone changes will be there.
Why muscle wasting? You're expecting it's an upper motor neuron type of lesion or lower motor neuron type of lesion?
So upper motor neuron type of lesion. But sir, I'm expecting, since the child has feeding issues also, and also has since the last 2 years.
So what do you call it? Say the malnutrition.
Yes, sir.
Right. Okay. Yes. What else? Take it further. What you are expecting on examination?
So tone changes will be there. So child might have spasticity or rigidity in hypertonia, that is, and power may be reduced. Reflexes may be brisk, and sensory system may not be involved. And yes, sir.
Do you expect the hepatosplenomegaly in this patient?
So hepatomegaly may be there because of the severe malnutrition part.
I will say it's a case of Tay-Sachs disease.
Yes, sir.
Why we should discuss the cerebral palsy?
But it is non-progressive.
Where this Tay-Sachs disease is classified?
So it is the type of storage disorder, but it will be a neurological
CNS point of view, where it is classified.
Means, sir, which part is affected? Like that's what you're asking.
It's a degenerative disorder.
Degenerative. Yeah.
And CNS degenerative characteristic should be the regression. So there is no question of regression. That's why I'm not expecting hepatosplenomegaly. You see why I'm asking this question? Somebody will ask in the exam. Right. Therefore, we should have the idea. Okay. I think what we are expecting, number one, if we see that generally the patient, probably nutrition must be affected and multiple nutritional deficiencies may be there. I will check for that. Size of the head probably may be small. That is macrocephaly. I would like to see for this hearing and vision, expecting that maybe might have been affected. Particularly, even sometimes respiratory infections may be common. Due to the constipation, even distension of abdomen or fecal mass may be palpable. Due to hypertonia or something, there may be some, even the contractures or deformities, or early some of these manifestations may be there. Even on CNS point of view, gross delayed development, hypertonia, or you can say answer, one line answer, the signs of upper motor neuron type of lesion. VT1, dystonia, and some other manifestations of extrapyramidal systems that I would like to see for this, particularly the posture, even these movement, abnormal movements also can be there, which we should check. I'm sure that these are the findings which we are expecting. Now let us see what Rahul has brought. Rahul, you can share your PPT.
Yes,
and go for the examination.
2 minutes, sir. Just. Yeah. On examination, child was examined in supine position in mother's lap. Bilateral upper limbs were in flex position and lower limbs extended with ankles plantar flex with occasional arching of the back. Child is irritable but is consolable by the mother. Vitals, temperature was 98.6 degrees Fahrenheit. Heart rate was 120 beats per minute. Respiratory rate was 24 breaths per minute. BP was 98 by 68 mmHg. Peripheral pulses well fed and regular and equal in both the limbs. Head-to-toe examination. Head appears small in size. Hair is lusterless and not easily pluckable. Anterior fontanelle is fused. Eyes appear normal. Pallor present. No icterus or pyoid spot seen. No low-set ears. Neck, bilateral subcentimetric lymph nodes are present, 0.5 to 0.5 centimeter. In the right group, posterior, fifth group. No rachitic rosary, no pressure sores or ulcers, no contractures. 2 centimeter by 2 centimeter cafe au lait spot is seen on the back and the trunk. Anthropometry, head circumference for girl, it is coming between a -2 to -3 standard deviation. Then weight for age is coming less than -3 standard deviation.
Rob, can you make it full screen?
Sorry. Yeah. So head circumference was coming between -2 to -3 standard deviation. Weight for age was less than -3 standard deviation. Height for age was coming at -2 standard deviation. And weight for height was coming less than -3 standard deviation. So classified as a severe acute malnutrition. So systemic examination, central nervous system examination. Child is irritable but awake. Noticed to have dystonic movements of bilateral upper limbs and lower limbs. Higher mental functions could not be assessed. Cranial nerve examination, one, not assessed. Second, visual acuity is not assessed. Visual pupillary reflex are round, regular, and reactive to light. Fundus was done, which was showing no papilledema or optic atrophy. Third, fourth, and sixth nerve, direct reflex present, indirect reflex also present, and extraocular muscle full range of movement, and no apparent squint is present. Sensory, pain response to pain and touch is present. Motor is also intact. Jaw jerk is present. Seventh, no deviation of angle of mouth, no loss of any nasolabial fluid. Tight closure of eyelids is present. Eighth is a response to loud sound and turns head. Ninth and 10th, palatal movements are present and equal. Gag reflex is present and uvula is center. Ninth was not assessed. 12th, no fasciculation of tongue and no deviation of the tip of the tongue is present. Motor system, bulk appears comparable on both the sides. No muscular atrophy is seen. No limb circumference disparity is seen in both upper limb and lower limb. Tone increase in all four limbs in both extensor and flexor compartment and is velocity dependent at ends of flexion and extension. Tone was increased in the lower limbs more compared to that of upper limb. According to modified Ashworth scaling, it is coming to grade 2. Spasticity is present. Power as per MRC grading of muscle weakness. Movement at shoulder joint flexion and extension only I could assess. It was 4/5 in both right and left. And at elbow joint in flexion and extension, both 4 and 4/5. Movement of wrist, flexion extension more than 4/5. Hand grip could not be assessed. Reflexes, corneal reflexes are present, conjunctival also present, abdominal present, plantar are present and upgoing. With deep tendon reflexes in the upper limb, if I have found reflexes were not brisk, like 2+2+, they were present in biceps, triceps, and supinator, while knee and ankle 3+ it was present, with no clonus elicited. Clonus was not present. Neonatal reflexes, among the ones examined, glabular tap was present, cortical thumb absent, and crossed extensor reflex was present, persistent. Coordination and abnormal movements. Coordination could not be assessed, but abnormal movements were present. The movements were abnormal tightening of bilateral upper limbs and lower limbs. In the upper limbs, the movement occurred and then the posture is held for some 10 seconds and then resolution takes place. Then it improves on its own. Sensory system, pain and pressure are intact both on right and left. Basically, pressure checked and the child responds to the pain as well as pressure. Posterior column sensation did not assess. No signs of any meningeal irritation. Gait could not be examined. Spinous processes are just visible. So, and skull is normal. Other systemic examination, cardiovascular system is normal. Respiratory system, chest movements are equal bilaterally. Normal vesicular sounds heard. Per abdomen, soft, non-tender, no organomegaly. Yes.
Okay, can you stop sharing?
Yes, sir.
I think, Dr. Abhijit, can you take this examination points?
Yes, sir.
Yeah.
So precisely, if at all I ask you to summarize your all positive finding as a summary of clinical finding, what you would, summarize it as?
Summary, sir, cranial now, in general, there was no cranial nerve deficit
No,
except the first
starting from general examination.
general examination.
Find out some point in the general examination.
Yeah.
So to give me little clue, window towards the CNS examination. Yeah.
Okay. The child was sitting in the mother's lap, usually with upper limbs and lower limbs, upper limbs in flexion and lower limbs in extension with plantar flex position. One thing. Then head to toe examination, I found that the head is appearing small in size and lusterless hair, but no other signs of.
That's okay. Just give me positive thing, which will tell me which will kind of guide me to the final diagnosis.
Okay.
I don't want you to elaborate again.
Yeah. Then nothing. A motor in the flexion extension in joints were 4/5, and the reflexes I found in the upper limb were 2+, but in the lower limb 3+. And spasticity was also present in both upper limb as well as lower limb, but in the lower limb it was more compared to that of upper limb. And according to
enumerate which of the muscle were spastic or spasticity was throughout?
Spasticity was throughout. Spasticity was throughout.
So you wouldn't appreciate in group of muscles?
No.
Okay, so on passive movements, you could get spasticity in all muscles, all muscles in lower limb, little more than as compared to the upper limbs.
Yeah. In the lower limb, more compared to more than upper limb. So that's why I classified it as grade 2 as well, sir, because movement were easy, but they were there was spasticity throughout. So that's why.
Would you like to say it is spasticity? How do you differentiate spasticity and rigidity?
Spasticity usually rigidity is throughout the movement and is not velocity dependent, while spasticity is velocity dependent and means velocity dependent as well as at the end usually there is a catch.
Okay.
End of the movements, and rigidity is basically like lead pipe. So throughout the movement there will be increased resistance, while spasticity at the end of movements there is leap, means the toe suddenly loss of toe. So it is like velocity dependent, basically velocity dependent and not velocity.
Do you have any distribution in spasticity in group of muscles, or you would have in kind of a so the preference of spasticity in muscles? So which of the muscles in upper limb would be more spastic? Which of the muscles in lower limb would be more spastic? If at all you're thinking of the periventricular or cortical lesion?
If we are thinking, the anti-gravity muscles are have a tendency of being more spastic compared to that of non-anti-gravity. So the thing mostly if we are talking about the flexor group of muscles in the upper limb will be more spastic, and in the lower limb the extensor, the quadriceps.
So typically when now you're coming to the point, so typically in upper limb, what you have the posture like the like the elbows are flexed, it is kind of close to your body, and the wrists are kind of flexed.
Yes.
So all your bicep, your supinator and flexor of the wrist will be kind of a spastic as compared to the other muscles.
Yes.
And lower limb, which of the muscles will be spastic? As we say, scissoring. So scissoring, means which of the muscle groups are kind of sir has already
one thing will be adductor muscles. The adductor muscles will be spastic if scissoring is present.
Very good.
And the limbs are in an extended and plantar flex position. So
which are your anti-gravity muscles? So just kind of imagine when you're standing. So which of the muscles will be kind of activated when you're standing?
When I'm standing, it will be this quadriceps.
Okay.
Anybody
wants to differ on this?
Standing.
Hamstrings will cause extension at the knee joint.
Yeah. So basically hamstring and gastrosoleus. So those are the muscles and adductors of the hip.
Yeah.
So yeah. So now with this introspection into it, so do you want still to kind of stick to your, kind of a distribution of kind of a tightness or spasticity along all muscles, or do you feel there was some differential spasticity?
So muscle group is saying, sir.
Yeah.
Yeah. Muscle groups are in the upper limb. I would say that the flexor group of muscles were more spastic.
Okay. So you feel, I mean, there is kind of some distribution change. Because at this your level C, I mean, I'm kind of want to make you kind of learn this thing. So when you have rigidity, you have throughout, and you kind of got this concept very right theoretical. And what about contractures? Because you said in general examination there are no contractures.
No, no.
So what is the difference between a dynamic and static contractures?
Static contractures are dynamic contracture are the ones which on passive movement you can have a good movement at the joint side. Means so means when we are doing the passive movement, there will be movement at the joint. By static contracture, it will be difficult to even during passive movement by the examiner.
So there is something which is called as catches. This is R1 and R2, right? So the place where you first catch is your R1. So till R1 you can go well, and R1 to R2 with a little extra force you can make it, and you can get the full range of movements. So that is what is your dynamic contractures, where there is no contractures and you can have full range of movement, but at the end of moment after that catch you will have to put a little more kind of pressure. Versus when you have static contractures, your R1 and R2 is almost same. So you come to the catch and then you can't kind of have the range of movement to the fullest. There will be some limitation of these movements. So again, on your examination, I want to confirm it, you didn't had any kind of a dynamic contractures as well there.
No, sir.
Yeah.
No, sir.
Any maneuvers that you say a couple of reflexes. You said lamellar tap. You said, I mean, there was cross extensor, and you say there was one more. I think one more. I just missed it.
Cross extensor, glabellar, and this cross extensor. I also forgot.
Okay, fine. So did you check for snout pout? Did you say, I mean, see for, I mean, asymmetrical, I mean, kind of a neck reflex, or did you see for Moros?
Moros, sir, I did not elicit. Means I elicited, but I did not get it.
Okay, good.
But this the snout pout, sir, I did not. I don't know, sir. Asymmetric.
You have to kind of you have to stroke around your kind of upper jaw, around the maxilla and lower jaw, and if you see the movements happening around your, I mean, facial muscles. So it is again one of the, I mean, kind of a thing which you get. I mean, one of the primitive reflexes which you kind of preserved in cerebral palsy. Then what about your maneuvers? So on pull to sit, on ventral suspension, and met to sit, whatever the baby was doing.
Pull to sit, there was partial head lag. Pull to sit, there was partial head lag was present. While this ventral suspension, I did not do so much. Little bit big kids are 2-year-old, so that's why. And
prone?
Prone also, no, sir. Prone, I don't.
Okay. And see, when you say this cranial nerves, when you're saying the baby was not kind of not suggested. So in this kind of baby, when you have like global developmental delay and lots of kind of behavioral issues and lots of kind of dystonic spells and all these things, how do you assess the vision?
Assess
vision. It just seems your fundus was okay. There was no cortical atrophy, but still baby was not kind of, yeah, exactly. So what thing will tell you the vision?
That visually the child is okay.
Yeah, exactly. The child is visually impaired, or child was visual inattentive, or child is
visual tracking, sir. We can.
So what is the first thing which will come in vision assessment?
Visual
because on history you told it very rightly. Because baby kind of recognizes mother, smiles at mother, and all these things. So what kind of a examination finding on history you elaborated, which on examination you should have?
Visual tracking, sir, usually get.
Before that, what comes? See, visual tracking comes, which is secondary thing. What comes first before visual tracking?
Eye contact.
Very good.
Fixation and eye contact.
Fixation.
Fixation, yeah. So the child will start fixating. So showing a toys, I mean, when you examine, meaning when the child was making an eye contact, when the child was making an eye contact, looking at you as a stranger. So that was something which will give me, okay, there is some kind of a visual attention. It is there. Of course, tracking, because look, I mean, with this GDD kids, you may not have the full kind of a cooperation that baby will kind of do the tracking. And again, I mean, some pleasurable thing, you get some, I mean, kind of a, I mean, bright object. You can show some, I mean, torch is definitely bright because kid won't follow your torch, but a bright toy and all these things. Or maybe you ask mother to move around the baby. If the baby is tracking the mother, because mother is something which is familiar, definitely when you are around the baby, baby will get stranger anxious. And when those things are there, definitely you have some kind of a visual kind of a, what do you say, think about the baby there. Yeah. And if at all you want to summarize this all findings, so how, where, I mean, now coming to this question again. So where in the neuro axis you will summarize, I mean, kind of locate these findings to?
Because of the involvement of all four limbs, first thing, spasticity is present. Secondly, the abnormal movements are also present.
No, but then when you're saying all four limbs, do you have any differential in that or a kind of a preferential involvement when you say all four limbs? Because you told this on examination.
Yeah. Yes, sir. So I did not understand.
So do you have
lower limbs are more involved. Is it
Yeah.
right?
Yes, yes. Lower
exactly.
limbs are more
Lower
involved
limbs are
than-
more involved than upper limb, right?
Yes,
Yeah.
yes, sir.
Then you have spasticity, you have brisk reflexes, hyperreflexes in lower limb.
Yeah.
Plantars are extensors.
Yes.
Yeah. And your couple of neural reflexes are present.
Present.
Is it?
Yes,
and no obvious microcephaly, some kind of malnutrition, some pallor, some anemia, and all these things are there.
Yes.
So now on neuroaxis, where are you locating this region at?
Depending upon now, sir, I will say it is cortical involvement, but because lower limbs are more involved, I will say periventricular area because lower limbs are involved. This periventricular area, if I am considering only thing, then there is nothing to explain the abnormal movement. So I will say with periventricular leukomalacia, along with that basal ganglia.
So why are you saying periventricular leukomalacia? Why are you coming to leukomalacia? So periventricular leukomalacia in which condition you get?
Usually preterm.
Yeah, so preterm, large head, many other things. So here you don't have those kind of headers to stay as a PVL, right?
Yeah.
So periventricular, I mean, some pathology.
Some pathology. Periventricular.
What periventricular pathology can start at this stage?
Periventricular pathology.
If it's not PVL?
Cystic encephalomalacia.
Pardon me?
Sir, encephalomalacia or cystic change.
Yeah, so that could be one thing, but there is no, I mean, straight header towards it, right? So of course that is one of the possibility, but then that's what I'm saying. So apart from PVL, any other thing?
Periventricular involvement.
Calcifications.
Okay, let's anyways leave the etiology. Fine. So periventricular area. Which other area you feel is involved?
Basal ganglia.
Basal ganglia, globus
pallidus. Very good. So what are the, and you say cortical. So what are the things which are telling me is cortical on examination?
Cortical involvements are the involvement of all the limbs, all four limbs involvement. Then upgoing
that can happen even kind of internal capsule and periventricular white matter, right?
Yeah.
So what is something which is telling me is cortical?
Global development.
Okay, you can attempt it, yeah.
Global developmental delay.
Very good. So cognition even is going down.
Yeah. Then
anything more?
Upgoing plantars. Upgoing plantars.
So, see, these are motor manifestations. This is towards white matter. So again, as you say, you are not pretty sure about fixing and following. So those are special senses. Again, there is some issues. There is no kind of arousal too much with the noise. With the mother's noise, you will kind of see and look all these things. So special senses are not developed to that kind of a level. True. And kind of you have those kind of seizures or whatever things. Those are things are little more distinct. So what are the one couple of things which would be little more, and I would say is more of cortical. So I would say is, of course, now this mix of basal ganglia, white matter and cortical.
Yeah.
Right?
Yes, sir.
Anything to suggest is cerebellar?
Cerebellar.
Head drop.
Yeah. Head drop, but no. Head drop, why?
Very unlikely. So at examination, we are not something, because see, he's not doing anything. So we can't really get into the thing. And again, what you'll see in cerebellar thing?
Cerebellar.
There would be hypotonia in
hypotonia. Then titubation can be elicited.
Yeah. Anything in eyes you would look?
Nystagmus.
Very good. Very good.
Nystagmus will be there.
Yeah. Anything in brainstem that you're looking at?
Brainstem.
So now we are localizing the pathology. So do you think there's a brainstem involvement or no?
The upper limbs would be more involved than lower.
Yeah, so it would be little dense, right? Because this all tract kind of aggregate there.
Dense.
Little more dense there. Again, I mean, no little differentiations, all equally affected in that thing. What else would have been there in basal ganglia? Sorry, brainstem. I'm so sorry.
Brainstem.
Yeah.
Cranial nerve involvement.
Very right. So what do you expect?
This
Bulbar palsy.
Bulbar palsy is oculomotor change. Because see, many times Heilmann malformations, your hypoplastic brainstem syndromes, Jubers, and all these things definitely can come like this. So definitely no oculomotor abnormalities. Your pupillary reflexes are okay. Facial nerve seems to be okay. Vision seems to be not really bad. Of course, not ruling out, but definitely not really on the high order cards. Right? So where we are little localizing this to, I mean, and would basal ganglia alone will give rise to, I mean, kind of cognitive delay as well, or cognitive impairment as well?
Basal ganglia itself, less likely, sir.
Yeah. But is it impossible?
No, not impossible.
Yeah. What is it called? It's called subcortical dementia.
Okay.
So when your basal ganglia are kind of affected, and again your cognition, your kind of a higher mental function will be kind of a deranged, and again it could be a part of your subcortical dementia. So mainly corpus striatum will be affected. So now we're looking at something which is around basal ganglia, something around white matter tract, something around cortex. That is something we are looking at, right? On your this thing, and along with some spatial sense involvement. True, sir. I would like to stop, and I would like Harsh to take over. You take over again.
I think very nicely analyzed. Dr. Harsh, would you like to take it further?
I think it's really very elaborative analyzed by Dr. Abhijit. I think we can go ahead. What could be the etiological possibilities from you?
Yeah.
And then if at all investigation available, we can move ahead.
Because now at even few minutes, 5 to 10 minutes. So
Yes,
we
sir,
would like to utilize the anatomy and every aspect. I think Dr. Abhijit has done very nicely, which we can keep in mind. Always try to define exactly that which part of the brain is affected. Every part is having certain characteristics that you can find it out, put on a paper, and that will give the idea. I think this patient very rightly said that cortical involvement is quite obvious. Even the basal ganglia involvement is quite obvious. There is no sign of cerebral involvement. Brainstem is out of question. And having this, even this type of the clinical presentation, we can find out. Some of the points I think very rightly said in the exam also, you should keep in mind that involvement of all the 4 limbs, but even differential involvement should be kept in mind. I think in this patient, lower limbs are more affected compared to the upper limbs, according to Rahul's findings. Not necessarily always that type of the things can be diplegic or palsy, what we say in a preterm baby. Even following this encephalopathy, what I think Dr. Abhijit left later on, that what is the another type of the pathology where periventricular area may be involved. Suppose if it is not preterm, it is not leukemia, but still if the involvement is lower limbs are more involved, highly indicating that periventricular area is affected. And that
periventricular hemorrhagic infarct can be there.
Absolutely, Nishi, and that should be from the blood supply point of view. When the blood supply is compromised, and that can happen even in the term baby also. So that we can keep in mind. Having these certain questions, I will say from exam point of view, here addressed very nicely. Now we have the few minutes, so best ways to utilize it. I may not go in the further. Again, repetition of the summary, because already we have done in the history very well. With these findings, you can, I will say, take it to the last one. You have any investigations, Dr. Rahul?
Yes, sir.
So I think address the investigations.
2 minutes.
I think 1 minute, this previous slide, regarding the growth.
Yeah. This one, sir?
Yeah, growth chart.
Yeah.
Rishi, what is wrong with the growth chart?
Sir.
In the plotting, any mistake he has done?
What?
Why I'm putting, growth chart examination, in the examination growth chart is very important. How to plot it, yes. Dr. Sagarika pointed out that don't circle it.
Okay.
Just put at the top. Right. I saw in these multiple places, but this is very important and many students are doing this mistake. So don't give the space to the examiner to find out something, right? Okay. You can go for the investigations.
The diagnosis will say the diagnosis.
Okay, you can go with your possibility, no problem.
Yes, 2-year-old child with history of query perinatal asphyxia, with mixed cerebral palsy, dyskinetic cerebral palsy with spastic quadriplegic CP, with no visual or hearing deficit, with global developmental delay, with severe acute malnutrition, with no obvious contracture, with dystonic movement, with possible etiology being bilirubin-induced neurological deficit, hypoxic ischemic encephalopathy, or rarely neurometabolic disorder.
Okay, I think most of the points already covered in the discussion. You can.
I would like to ask one question to Rahul.
Yes, sir.
If you are the treating clinician and there is scarcity of the investigation money and all these things, which is the only investigation you would ask for and why? Not routine, specific and all these things.
Rahul, this is going to be the common question when you are having the good scoring. What Dr. Abhijit mentioned. On the contrary, you know that what we were taught, I will say. No investigations are required in the cerebral palsy. But I think with the modern our learning, it's not so. And suppose if you have the very limitations, rather than making list of investigations, what will be your priority?
So if you say this is not, or maybe you want to prove or disprove, I think somebody has already answered.
I want to do
if
MRI.
You want to prove, yeah. So if you want to prove or disprove anything, and why? Why you want to prove or disprove the things?
Yeah.
See, what difference does it make? I mean, if it is like kind of status encephalopathy versus a neurometabolic and neurodegenerative disorder.
So the management completely differs. So that's why.
Okay.
If it is, yes, sir.
And management and?
Management means if it is a cerebral palsy case, then it will not progress. But neurometabolic.
No, that's okay. So management will kind of determine, prognosis will be determined. And what else?
And
what we're a little more worried about? So any treatment options are there, we definitely kind of find out the treatment options of any neurometabolic disorder. Very good. So Viraj, I think
should
one
not
more
be
thing.
treatable cause.
So see, this is the first baby, isn't it?
Yeah.
And we definitely don't want this to repeat in next kind of a sibling.
Even genetic counseling.
Yeah, that is something we are kind of looking at, and everybody is like, I think everybody would be like really kind of hoping up of what will be coming up, and that is even kind of a surprise for us. Even let's see what is it. Yeah.
So even by this MRI, you can detect some congenital malformations. Even from the very specific pattern, you can suspect some neurological disorders. In the form, even degenerative disorders or so many other varieties, which probably now we have this offer the treatment with a good prognosis, good management. And from this point of view, otherwise we were taught in the past that if MRI does not require or any neuroimaging does not require. But now with this our learning, it has been changed that yes, definitely it makes difference in our thought and even the further workup and evaluation and even the management, even including for future counseling. So that's very important. Okay.
So investigation CBC we had done SAM and RFT with electrolytes, which will come normal with normal limit, and most important is MRI.
Can you make it full screen now?
Sorry. Yeah. This one's.
Do you have the images, MRI images?
No, sir. MRI images did not have, because this was the report which was from this CD's images. We don't have, sir. I don't have. But this was the report interpretation which they had given. So area of altered signal intensity involving bilateral globus pallidus appearing hyper-intense on T2 and flare-weighted images. Altered signal intensity seen involving anterolateral thalamus extending to the subthalamic cerebral peduncle. Myelination appropriate for age, mild thinning of the corpus callosum, and EEG was done, which was within normal.
Anything else you have?
Sir?
Crowd, any further?
No, sir. No,
okay,
sir.
you can stop sharing.
Yes.
I think this is the beauty of the clinical examination, which I would like to bring to your notice. That from the history we started, that which part is affected. MRI showing probably almost the same. Am I right?
Yes, sir.
And that's why it is, I will say, Dr. Abhijit, any last comment from you, or can we go for winding up?
Yeah, sorry. Basically, now, like looking at the MRI findings, now we again anterolateral thalamus, some globus pallidi, and all these things. Definitely, what Harsh was asking was the MRI films, because many times what happens is MRI reported and MRI seen are entirely different things. And as even sir mentioned, there are pattern recognitions. I don't want to get into too much of complexity to tell what is it and what is not it, but definitely it has to be kind of a very well seen, because there are a couple of things, especially infantile striatal necrosis, your biotinidase thiamine responsive ganglion disease, it's a treatable metabolic disorder, which may look like that. What is something which will tell me is more HI is like gliosis. So if at all there are gliotic lesions, there are peri-Rolandic area, which is gliotic and all these things, I would kind of put it more to the CP point of view. Of course, this distribution, anterolateral thalamus, some kind of a basal ganglia, and the peri-Rolandic area is showing me gliosis and your bulbar dysfunction. Definitely, I would put it as a central HI rather than like other that your encephalomalacia. While the distribution of MRI is kind of a different, then I will definitely go ahead with your battery of investigation, including your screening metabolic test, then your genetic test and all these things. So now, if at all, one of the differential was your connectors induced encephalopathy.
Yes,
so what is the surrogate marker that you will kind of do and would kind of prove it as bilirubin induced encephalopathy, which is readily available?
Surrogate marker.
Anybody? So which are the areas which are stained by
So which
Did
are
you
the
get the question?
no,
Which
sir,
are the
which are
areas which are stained by bilirubin? Yeah.
which
So definitely, you know,
So the
delayed-
hippocampus and the basal,
hippocampus and the basal
hippocampus
that
and
too we know,
basal.
brain. Apart from brain, I'm talking about. So there will give you that will give you the clue to answer this question.
Dr. Abhijit, what will be your interpretation, point of particularly the pathology or etiology point of view? What is the information we have in this case?
Yeah, this baby, sir, I would definitely think, I mean, we don't have the labor details. There was some suspicious history of like delayed cry and all these things. Definitely a central HI. I mean, may not get into the stage 3 or stage 2 of HI. That subtle irritability or subtle not refusal to feed and all these things would have been taken little in kind of a detail. So that thing will tell me, okay, is HI or not HI? And definitely this thalamus won't come in your bilirubin induced, and bilirubin induced will have surrogate marker as a BERA. So BERA will show definitely abnormal. The child won't be kind of a blind and kind of a deaf, but you have high frequency hearing loss, which will tell me it's a bilirubin induced.
BERA is not done, Dr. Rao.
No, sir. BERA is planned, sir. No,
yeah, it's planned. Okay.
Yeah.
Anyway.
And then depending on the distribution on the MRI, I would think about other differential, as I always say, I mean, couple of mitochondrial disorder, organic acids and all this, but very unlikely looks like, but then definitely need to rule out because this is in the first baby. And
absolutely.
Definitely, yeah. And definitely if the baby is showing little kind of odd features, so if at all the baby is kind of getting better, again regressing, kind of waxing waning course, I'm getting little kind of a severely affected in kind of illnesses, again, that will give me a little more clue towards a neurometabolic disorder. And I would like Harsh to add his comments on this.
Yeah, Dr. Harsh, anything?
Yeah, I think already covered by Dr. Abhijit. In the history, if you don't have a evaluation of jaundice, I would like to ask the mother that whether how's the soles. So the soles of the and the hands, if they are yellow, then definitely the jaundice is significant. But if mother could not recollect or could not tell that much severe jaundice, then difficult to label them straight away as a bilirubin encephalopathy. I would like to further etiological causes also to be ruled out, as Dr. Abhijit has mentioned, because so we would like to review the MRI rather than going straight away with only the reports were telling us. So anterior thalamus, anterolateral thalamus is very unlikely with bilirubin encephalopathy until unless some other insult is there. So definitely we need to keep our possibilities open in this case if this MRI report is very correct.
Yeah. So I think at the end we come with the conclusion that in this patient number 1, first interpretation of the MRI is very important. What the experts mention and whether does it satisfy us from the specific etiology. Second, we can go for the beta. And I think that will also help us that how much we should consider the sole etiology and the bilirubin encephalopathy. And if probably we are not happy or confident from these, satisfying the only etiology from the hypoxic or the bilirubin encephalopathy, we should keep our mind open for further workup or some even these inverter of metabolism or some other neurometabolic conditions, which probably will be, if we come to the conclusion, very useful for this management and even for the future counseling. So I think these are the points which we can consider over here, and let us end over here because already we have crossed the time. So first, definitely, Dr. Rahul, you have presented very nicely.
Thank you, sir.
Even in the history, you have gone at, I understand that at the end of 3 years and after 30 years, to derive the history is always different. But you have done definitely a good job. Even examination of the patient also done in a very appropriate way. Probably what we want from you, follow-up if it is possible, interpretation of the MRI and BERA, probably that will help us for further learning. And of course, this credit goes to your mentor. I understand that must have taken the lots of the pain for preparing this type of the presentation, and all even your colleagues. Some of the colleagues were, I would say, participating very nicely. Let me mention even the Nishi and Chandan and even the Viraj and Virat and even some of your friends. What I will suggest to other students that always on the screen, keep your video on. Not necessarily it is compulsory for us to speak, but at least by keeping the video on, you achieve the one step. Second step, later on, we can go for participation and speaking, but I think that we should do. Of course, in the due course of time, everybody learns. Thank you very much. And we know that this, for this type of the running the show, Dr. Nehal and Dr. Vaishali Madam and all these teachers, they are taking so much pain that finding out the proper center, even the presenter, and coming for this presentation. So of course, this is also very important that how much they are taking the pain. Thank you very much. We'll end over here. And next Saturday with some new case, again we'll be there. Dr. Vaishali, over to you.
So Dr. Vaishali, I couldn't join because of some network issues. This is Dr. Anagha, was mentor for the case discussion.
Madam.
Yeah.
Madam, we saw your, I will say, mentoring. Well done. And I will say that was a good presentation. Even experts, Dr. Abhijit and Dr. Harsh also appreciated. I can see even some of the teachers also on the screen. Dr. Charud is there and some of the teachers are also there. Thank you very much. Over to you, Dr. Anagha.
Yeah, so I'd like to thank our esteemed faculty on behalf of the Department of Pediatrics, Goa Medical College, Dr. Prajapati sir, Dr. Abhijit and Dr. Harsh. The way you all have guided the PGs to delineate the pathology and the etiology was really nice. And CP is such a common case for exams. So this discussion be really helpful to them to answer their exams more confidently. Yeah, thank you so much.
Thank you very much. And good night,
good
everybody.
Evening, sir.
Yes, good evening, Dr. Charo. Nice to see you. Yes, Dr. Sagarika is also seeing so many, I would say, old friends. Still they are, I would say, maintaining the interest. That's good. Thank you very much, everybody, and good night. Next Saturday, again, we'll be there.